Good evening, all. I'm Dr. Prajakta Sahasrabuddhe. I'm Associate Professor, CVRS Department, Sancheti College of Physiotherapy, Pune. I would like to welcome all of you to today's Physio TV session on physical activity in COPD, implications and future directions. And for this session, we have a renowned speaker, Dr. Shweta Gore. Dr. Shweta Gore is an associate professor in the Department of Physical Therapy at MGH Institute of Health Professions, Boston, USA. She has done her master's in physiotherapy from Manipal University, PhD in physical therapy from University of Michigan, Flint, USA. And now she herself is a PhD guide. Dr. Gore's research focuses on the measurement of physical activity and its relationship with health outcomes in individuals with chronic cardiovascular and pulmonary conditions. And she is currently working with Johns Hopkins Health System to design and study the implementation of Johns Hopkins activity and mobility promotion approach to hospital mobility across Boston Medical Center hospital system, and also evaluating its effectiveness. We are very happy to have you for this session, ma'am. Over to you. You can share your PPT.
Thank you, Prajakta. Thank you for the kind introduction. I will share my screen. Okay, so hi everyone. It gives me great pleasure to coming back to Sancheti, and this is where I started my career as a clinician and academician. So today I will be talking about physical activity in COPD, its implications and some future directions. So we'll be talking a little bit about my research in this area. So to begin with, just to know about what physical activity really means, it is generally defined as any movement that occurs as a result of muscle contraction, and then it can in turn causes energy expenditure. When we talk about physical activity, there are two types of activity: structured, which involves supervised exercise, and incidental activity, which is activity that is unsupervised and performed throughout the day, which may be for either leisure or work. So it is important to know that even incidental physical activity, just like exercise, will include 4 dimensions: mode or type of activity, frequency of performing activity, duration of activity, and intensity of activity. So now moving on to COPD. We know COPD is a chronic, progressive, and non-reversible airflow obstruction. It is a huge burden on the economy due to the high healthcare utilization. It is the 3rd leading cause of death in the US as well as worldwide, and 5th largest contributor to disability in the world. When we look at physical activity in COPD, you will note that physical inactivity or lack of activity is very common in individuals with COPD, even in the early stages of the disease. So even those who have mild disease, the average activity is 40 to 60% lower than their healthy counterparts, which is particularly concerning in COPD because it leads to this vicious downward spiral of mobility. What it means is that disabling symptoms of COPD, such as dyspnea and fatigue, can often force these individuals to limit their physical activity. And limited physical activity in turn leads to deconditioning, disease progression, and depression. So let me give you a closer look at this downward spiral of mobility, of dyspnea. So any primary respiratory impairment we know will lead to dyspnea, right? So dyspnea, as we all know, is a very unpleasant sensation. To avoid this sensation of shortness of breath, individuals will limit their activity. So for example, if the dyspnea initially came with moderate exertion, patients will not want to go into that moderate exertion level. So they will do less activity well within the moderate exertion stage, right? So this will result in deconditioning. Now, the deconditioning just does not happen only specifically to the peripheral muscles. It will also affect the respiratory muscles. It is just a generalized deconditioning. So because of this, there will be further disease progression. And the dyspnea that was first experienced at moderate exertion will now occur at minimal exertion. And this cycle will continue till the patient starts demonstrating dyspnea at rest, will become homebound, will be more dependent on supplemental oxygen. There will be depression, poor quality of life, and many trips to the hospital. So this is really the downward spiral of mobility, and which we need to break. So the World Health Organization recommends guidelines for physical activity for all healthy adults. And according to their recommendation, all adults should undertake at least 150 minutes of moderate intensity activity per week to maintain a healthy lifestyle. But specifically for COPD, the GOLD guidelines recommend that all patients with COPD should participate in daily activity. However, we don't yet know how much will translate to real benefits, right? So why is physical activity so important in COPD? Lack of activity is one of the 5 leading global risk factors for mortality in the world. It is well recognized that for healthy adults, physical activity, participation in physical activity can significantly prevent or even delay the onset of progress of many chronic conditions. In those who already have a chronic condition, physical activity can significantly slow the progress of the condition. On the other hand, lack of activity in COPD is associated with high risk of hospital admissions and readmissions. More specifically, so patients with moderate to severe COPD who have low physical activity have a higher risk of hospital admissions as compared to those who have high physical activity levels. So there was a large population-based study done by Garcia et al. Where they actually recruited 2,386 patients with COPD and followed them prospectively from 1986 to 2010 or so. And they found that participation in moderate to vigorous levels of activity in COPD could decrease the hospital admission risk by almost 28%. Not just hospital admission, but physical activity has found to be the most important predictor of mortality in patients with COPD. So irrespective of the level of physical activity, participation in regular activity could decrease the risk of mortality by 30%. So if you look at the hazard ratios, there is decreased risk by almost 30%, which is huge. So this is not even structured exercise, right? We're not even talking about supervised exercise. We're saying that if these individuals increase their activity throughout the day, the chances of them dying from COPD or from any other cause would considerably decrease. This is a huge finding. So then looking at physical activity and its impact on quality of life and self-rated health in COPD, well, looking at the previous evidence, it kind of becomes obvious that physical activity will have positive effects on self-rated health and quality of life. But what's interesting is that the probability of a higher self-reported health is almost 7 times greater in patients with COPD who are physically active. Also, probability of experiencing depressive symptoms and psychological distress is half that in those who are physically active. So additionally, being active leads to overall better functional status with high respiratory muscle strength, higher exercise capacity, lower systemic inflammation, which is a marker of disease severity and progression in COPD. So in short, there is abundant evidence that says that patients with COPD should be physically active because low physical activity is associated with really bad outcomes, more hospital visits, more cost burden, and so on. So considering this, the American College of Sports Medicine and Kaiser Permanente, they have called for all clinicians to consider physical activity as a vital sign and then implement physical activity vital sign assessment in daily practice with every patient. However, the problem is that the disease itself makes it hard for these people to be active, right? These patients have shortness of breath. What makes it even more challenging is that we don't even know yet the exact cutoff of physical activity that is needed to see benefits. For example, the 150 minutes of moderate intensity exercise a week, which is a recommendation for general public, that does not apply to these individuals. We need to establish new cutoff values for this population. But again, this is also not very simple because right now we don't even have a measure that will accurately assess physical activity in these patients. So again, I know that the question that many people would have is that there are so many methods that are already available to measure physical activity. So how come we don't have a measure? So let's really quickly take a brief look at these measures in the context of COPD. So when we look at assessment methods for physical activity, we categorize these into objective and subjective measures. In terms of objective assessments, the first one is direct observation, where you literally follow the patient wherever they go and observe the number of steps that they take. You count the number of steps and you record the steps. This is obviously time consuming and practically it is not possible to follow the patient around everywhere. There are places where you can't really follow them too. So it is not a very feasible measure. Then moving on to doubly labeled water or indirect calorimetry. So these are lab-based measures. They are often considered gold standard measures, yet the clinical applicability is really low, as clinical settings will not have these measures, right? These are only restricted to lab-based measures, so you can't really use these very easily in clinical settings. Then we have the pedometers and accelerometers. Now, these devices have definitely greatly enhanced the measurement of physical activity because they're small, they're portable, they're easy to take anywhere. So for those folks that are a little muddy on the difference between pedometers and accelerometer, pedometers are simple versions. They can measure movement only on a single axis, typically on a vertical axis. Therefore, you get limited information on the step counts from these monitors. Accelerometers, on the other hand, can measure movement on one or more than one axis. There are accelerometers that can measure movement across all three axes and therefore can provide more information on the angular velocity, energy expenditure, and so on. So considering the advantages of accelerometers, we set out to explore which physical activity measure is the most accurate or valid in COPD. We found that 19 different types of accelerometers and pedometers were examined in different studies to examine their measurement properties, right? And what we found was most of the studies that examined the validity of activity monitors in COPD either included pedometers or they included a accelerometer brand called SenseWare armband. What's interesting is that both of these monitors showed poor validity to capture physical activity in COPD. So pedometers were found to significantly underestimate physical activity in COPD, and therefore these definitely must not be used to assess physical activity in COPD. For SenseWare armband, while it was able to accurately measure activity in controlled lab settings where patients were able to walk on a treadmill, when the same study was performed in community dwelling patients where their gait speed is variable, where some of the patients walk really slow or they walk using assistive devices, when that was done, the SenseWare armband failed to demonstrate validity. So since we know that most patients with COPD are going to be community dwelling, they're not going to be walking on the treadmill every day. They're going to be they're going to have some changes in their gait speed, they're going to be using assistive devices. So we can safely say that SenseWear armband is not a good measure to assess physical activity in COPD. And the accelerometer that showed good validity was another brand called the Actigraph GTX Plus. However, only one study has been done so far on a very small sample of patients. So we need more evidence to generate before a strong recommendation can be made, right? So until then, hopefully the studies don't use SenseWear, because all of the studies in COPD are just currently using SenseWear armband or a pedometer. We also know that although pedometers and accelerometers give you some quantitative data, they do lack the ability to give you some qualitative information, like the type of activity, the patient's experience with activity. Other limitations that activity monitors have include their cost, right? So you have to, if you have to buy multiple accelerometers for a large scale study, it makes it really not possible. And so the high cost, subject burden, and the need for, you have to wear these monitors over several days to get some meaningful data. So there are patient compliance issues as well. So these limitations are overcome by subjective measures. The low cost, excuse me. These measures have either they are like free of cost, or they're really very purchased at a very low cost. These are definitely some of the practical choices for assessment of physical activity in clinical settings, as well as in large-scale observational studies. So this led to our second study, where we wanted to explore the measurement properties of subjective and hybrid measures of COPD, right? So we found 15 different types of activity measures, subjective measures, that were examined in 12 different studies. Out of these 15, 8 were self-administered or unsupervised measures, meaning that the patients were just handed a piece of paper. They just had to fill out the information and without any supervision. Then there were assisted measures, where these, which were supervised. So the interviewer sat with the patient, they gave them some prompts, some cues were provided by the interviewer. So those are the supervised or assisted measures. And it's important to note that PAR is the physical activity recall, and YPAS is the Yale Physical Activity Scale. So these were the two assisted measures. Then we had computerized measures, where responses were fed on a computer-based system. We had rater-based measures and hybrid measures. Hybrid measures are a combination of objective and subjective measures. So I'm just going to briefly talk about the results. So we examined both validity and reliability, but I'm just going to focus on the validity piece. So concurrent validity and construct validity were examined. Concurrent validity is where the subjective measure is tested against a reference standard, right? So in the studies that were focused on COPD, we found that most studies tested these subjective measures against a reference standard, and the reference standard that they used was the SenseWear armband. And some of the studies used pedometers. So they used an accelerometer, which itself is not valid, to examine the validity of the subjective measures. And what they found, though, is that the interviewer-based measures, so the supervised measures like the PAR and the Yale, as well as the computerized measures, both showed good validity as compared to the other unsupervised and rater-based measures. In terms of construct validity, it was tested against the 6-minute walk test as the reference standard. And we found that both hybrid measures and supervised measures showed good validity. So in terms of recommendations, we see that in the case of subjective measures, we have some evidence that shows that supervised measures have better validity to accurately measure physical activity in COPD. However, it is important to note that these findings were derived using SenseWare armband and pedometers as reference standards for majority of the studies. We've already established that these accelerometers are not good measures to capture activity. So using a reference standard that itself is not valid weakens the strength of these findings, right? So although we can say at this point that assisted measures and computerized measures are have acceptable validity and reliability, we have to take that with caution, because we have used some poorly valid reference standards to examine these validities. We extended these findings to conduct another study examining the construct validity of the Global Physical Activity Questionnaire in COPD. And we chose this measure because the Global Physical Activity Questionnaire version 2 has been specifically recommended and developed by the World Health Organization for national surveillance of physical activity in the healthy population across countries. And just like the PAR measure in the systematic review, GPAC is also an interviewer assisted or supervised measure, but has not been examined yet in COPD. So the purpose of the study was to examine the construct validity of GPAC in older adults with COPD. So I'm just going to give you a brief overview of the study. This was a cross-sectional study using data from the National Health and Nutrition Examination Survey, which is a secondary data set and which is publicly available. Standardized interviews and physical examinations to collect demographic and clinical information from participants is done in a structured way by NHANES using standardized interviews. And as far as the inclusion criteria, there individuals 65 and older with COPD were included, and COPD was confirmed, one, by a self-report of physician diagnosis of emphysema or chronic bronchitis, and then also by the presence of FEV1 over FVC ratios of less than 0.7 on spirometry. So we had in the NHANES sample from 2007 to 2012, there were 30,432 individuals that participated, out of which 636 individuals had COPD. GPAC score, GPAC gives the total physical activity score, which is calculated based on the guidelines provided by WHO, where 4 METs or 4 metabolic equivalents are assigned to each moderate activity, and 8 metabolic equivalents are assigned to each vigorous activity. And then the total score is calculated by summing all the moderate and vigorous activities, including work activity, recreation-based activities, and then they're all summed together. So well, this is a little bit, we use this data version to do all the analysis, and I'm not going to go into the details. We did like the demographic, we did some baseline descriptive statistics, and we did some multiple imputations analysis to account for the missing data in the sample. In terms of the results, we had 636 patients with COPD, and the COPD group had more males, more smokers, lower self-rated health, greater percentage of comorbidities, which is not surprising considering that they had COPD. So for convergent validity, we wanted to see if the GPAC total physical activity scores would be related to similar constructs. So we're talking about construct validity. So we found out constructs that have been in literature coincided with physical activity. So we looked at lung function and shortness of breath. So we wanted to see if GPAC would, total scores would be related to lung function. For lung function, we chose FEV1 as our dependent variable, and we did a multiple linear regression, adjusting for all the covariates. And what we found that it did not, the GPAC physical activity scores did not significantly associate with FEV1. Similarly, we found similar findings for shortness of breath, that the GPAC scores did not correlate, did not show significant associations with shortness of breath, indicating that GPAC failed to demonstrate convergent validity in this population with COPD. We also did known groups validity, and we found similar findings, right? So known groups validity is where we wanted to see if GPAC could differentiate between those who had COPD and those who did not have COPD. And our results actually found that GPAC did not demonstrate discriminant validity. So in conclusion, GPAC really did not demonstrate construct validity in older adults with COPD and should not be then used as a measure for physical activity. However, this is a big tool, right? This is very important tool. It is already nationally and globally being used. So we wanted to explore some reasons why we saw these findings. So one of the things that that we saw was that GPAC scoring sums the work and recreational domains in the calculation of total physical activity, but does not include the transport domain, right? So if patients who were walking or cycling in terms of transport, then that was missed out. Second, GPAC uses descriptors of activity, right? So it asks participants about, whether an activity caused large or small increases in their breathing or heart rate. So it's a very subjective way of asking this information. Given that individuals with COPD have high energy cost of breathing, even at rest, this subjective assessment of activity intensity can be highly dependent on the participant's perception of breathing responses. And then also, we did not look at, so yes, in literature, lung function and dyspnea are previously established constructs of physical activity in COPD, but there are also other constructs, right? Like exercise capacity, quality of life, self-efficacy, and those were not studied in this particular research. So in terms of physical activity assessments in COPD, this is how far we have reached so far. And so, as you can see, much is left to be done. However, taking a look at interventions to improve physical activity in COPD, since physical activity is a major independent risk factor that has a protective effect on important health outcomes, improving physical activity is an important goal in the management of COPD. However, if you look at interventions, currently, there are no interventions that are specifically designed with one goal of improving physical activity, right? However, we already know some of the well-established interventions, and these are bronchodilators, pulmonary rehab, and now there is physical activity counseling, which is also part of pulmonary rehab, but this is initiated at some places at the community level. It's very new. And is still in the infancy stages. So when we look at bronchodilator research, although several studies have assessed the impact of bronchodilators on the actual structural parameters like hyperinflation, hyperinflation, there is limited evidence on the impact of bronchodilators on physical activity. So there was a small study done in 2013 that showed promising results with improvement in physical activity following 4 weeks of bronchodilator therapy. But this was a very small study, and there were conflicting findings from a larger study. So a larger study with 90 patients showed no improvement in bronchodilator in physical activity following bronchodilator therapy. And since then, several studies have actually shown that bronchodilator therapy is not really very helpful in improving physical activity when given in isolation. So at this point, the current recommendation suggests that isolated bronchodilator therapy seems unlikely to achieve any increase in physical activity. So then we look at pulmonary rehab. Now, it is well known that pulmonary rehab does indeed aim to break the vicious spiral of mobility in COPD. Pulmonary rehab, as we already know, is a multidisciplinary program with supervised exercise training as one of the key components. So some of the goals of pulmonary rehab do say that pulmonary rehab aims to reverse the consequences of COPD. So at the structural level, it aims to decrease the sensitivity to dyspnea and enhance the efficiency of physical activity. So really, as you can say, that exercise training, which forms the cornerstone of cornerstone of pulmonary rehab, does have great benefits. So you can see that pulmonary rehab is the single most powerful intervention that has well-documented benefits on a multitude of factors such as dyspnea, fatigue, depression, endurance, dependence, muscle strength, efficiency of walking, reduced healthcare utilization and quality of life, as well as on physical activity, right? So how does it potentially improve physical activity? Basically, with the course of pulmonary rehab, the improvements in exercise tolerance and dyspnea and as well as strength can potentially then translate to an overall increase in physical activity, right? However, the problem is that the effects of physical activity are not as strong as on other aspects with pulmonary rehab. The results are heterogeneous across studies. So you can see that there are studies that show really positive outcomes on physical activity, and then there are studies that show no effect. And these are some older studies, and now since then there have been other studies. All of these studies still continue to show conflicting findings. So when we, as you can see here, in the studies, the duration of program is variable. Some are just short 3-week programs, and then other programs are 8-week programs. So you can see the longer studies have had positive outcomes. And then the other interesting finding is that the activity assessment that was used in all of these studies is variable, right? Some have used pedometers, some have used uniaxial accelerometers. So none of the studies has used a similar activity monitor. So all of these problems actually compound this whole problem of generating solid evidence for pulmonary rehab as a promoter of physical activity. The other problem is that even though pulmonary rehab might improve physical activity, there is little sustenance, right? So if we want to really improve activity levels, we have to bring about a change in the patient behavior such that they are self-motivated to sustain higher activity levels even after they're discharged from pulmonary rehab. So in COPD, it has been hypothesized that the reduced physical activity levels in patients with COPD may potentially have a behavioral element, meaning that patients are not mentally ready to increase their activity levels. They do great during pulmonary rehab. Like all of the pulmonary rehab literature, we have level A evidence that pulmonary rehab is a single therapy that helps improve exercise capacity, lung function, dyspnea, quality of life, everything in COPD better than medical management. However, once they get discharged from pulmonary rehab, they will lose all of these improvements if they don't maintain their activity levels. So improving baseline activity levels is more challenging than it appears on surface, because you can't just perform an intervention and then expect that the improvement in activity will sustain. Several factors are inherent to the success of physical activity interventions. These include patient behavior and environment in which they live. So patients should have the internal desire to maintain this change, and this requires the change to occur internally, right? So the other problem is their environment. Where does the patient live? What does the patient's support system, their friends, family look like? So if the patient is surrounded by friends who are runners, they're highly motivated in fitness, they watch what they eat, etc., then it automatically would improve or help the patient to sustain their own activity levels, as compared to when they are in the company of people who all they want to do is watch Netflix and eat burgers and fries. So we have had some research on isolated physical activity counseling sessions on patients in the community. Physical activity counseling sessions have shown some significant improvements in physical activity. Unfortunately, all of this work is still in the early stages and more research needs to happen in this area. So again, moving forward, looking at the future, we can already see that there is a lot of work that needs to be done to improve the care of these patients. For one, we still need a reliable and valid measure to accurately measure physical activity in COPD. Without a valid measure, we will not be able to tell the true impact of any intervention in COPD. Since GPAC is a globally used, it's already being used nationally, it's globally adapted, we need to explore it further. We need to explore its validity in a little more depth than what we already have. This is also an exciting time for physical therapy researchers because a lot of questions, we clearly need to answer these questions. Besides developing a valid and reliable measure, we need to find a stronger link between bronchodilation, pulmonary rehab, counseling, and physical activity. We need to develop physical activity cutoff levels that are directly associated to improve health outcomes, which will help to determine the dosage. And we need to move towards implementation science research. So implementation science research is already it's already ongoing in other areas, and this is where you bring your evidence to actual practice by incorporating physical activity at the community level following discharge from pulmonary rehab. So to conclude, you can't just leave these patients after discharge from PR or from pulmonary rehab. They need to be discharged to a behavioral modification intervention. So at this time, a combination of individualized pulmonary rehab program along with bronchodilators and behavioral modification post-discharge from PR is probably the way to go to improve activity levels. And in terms of activity assessments, until we have better tools that come up, we should rely on interviewer-assisted physical activity tools. And if you're using the accelerometer, then the Actigraph GT3 X+, until we get more research and better tools. All right, these are some of my references, and I thank you for your time.
Thank you so much, Shweta ma'am, for such a wonderful insight into physical activity assessment and how we can prescribe physical activity to COPD patient and where the current research stands right now, what are the lacunae, what are the limitations, where the future and young researchers should focus on. Actually, I had a couple of doubts. The first one is, you mentioned that no single outcome measure is right now able to assess physical activity with certain validity or accurately. There are wearable devices, there are subjective methods of assessment, but there is no uniformity in the research which says that this particular method has to be used. So in such a scenario, especially when I'm discharging patient from structured pulmonary rehabilitation and still I would like to monitor the activity or monitor the level of physical activity later. So what are the best options do I have?
Yeah, that's a great question. And I think once you discharge the patient from pulmonary rehab, it would be most feasible and ideal to give them some sort of a questionnaire instead of giving them an activity monitor. unless you have access to those. And if you are using that, then you can use an interviewer assisted measure. So I would recommend the physical activity recall questionnaire, or the Yale physical activity scale. Both of these are have shown good validity, although we know that it is against sense-wear armband, but they still are the most valid measures that we have at this point.
Okay, but then for periodic assessment, giving a questionnaire can be an option. But let's say I want to monitor the activity on the regular basis, that I have to tell my patient, okay, you have to do XYZ amount of activity. Then are there any wearable devices or anything else?
Yeah, so in terms of wearable devices, there is a wearable device called Actigraph GT3X4, GT3X Plus. It can be worn on the hip or on the ankle. It is a very valid, it is a valid tool. It's actually that showed the most promising results so far in COPD. Only that we don't have many studies that are that have replicated the findings, but I think that can definitely be used. It is higher cost, yeah, you have to consider the cost aspect of it as well. I would say also that right now we don't even know how much activity they should do, because we don't have those cutoff levels created yet. So any activity is good. So even if they can have their own, Apple Watches or some sort of like a Fitbit device, and they can count and they can have a log of it to say that, okay, I have done this much. I think that for now is like the most feasible option.
As you mentioned, all these wearable devices are going to be slightly expensive. So if we want to reduce the healthcare cost, especially for a underprivileged population, so are there any traditional options which can be used to monitor the level of physical activity, especially if the activity is structured one, but I want to remotely monitor it?
There are computerized activity questionnaires that are available. These questionnaires are not just they actually use the compendium of physical activity to calculate the physical activity as well as the energy expenditure. So you can monitor that remotely based on, and the patients will like feed into the computer system their activity log, and then you can remotely calculate the scores and energy expenditure on your end.
That's great. Okay. One last question. You also mentioned about the role of environmental factors in reduction in physical activity in COPD patients. So is there any outcome measure, maybe patient reported, it may be questionnaire based, which will help us to assess what are these environmental factors which might have a role in reduction in physical activity?
Yeah, I mean, it is already well established. Like there are several factors that play a role in limiting physical activity or impacting physical activity, and these have already been established and published. So I just mentioned one, which is the social support, but there's also like where they are living. So if they were living in a place which does not have any walking path, right? So if there are no walkways or walking path on the roads, and they're not going to, then they will just use the car and not walk. And then there are many others, and I can share that article. It has a list of established factors that will contribute to limited physical activity. Also, there are a lot of focused work is being done in the US to try to overcome those environmental barriers to improve physical activity for everyone, not just COPD, but for everyone. But again, that is something that is not without cost. So it's a work in progress.
Maybe sometimes reducing overuse of technology also can be beneficial in improving the physical
Absolutely.
activity in normal as well as patient population. I think we are overly dependent on technology nowadays.
Absolutely. That's true.
Thank you so much, ma'am. With this, we will conclude today's session. Again, I would like to thank you for such a wonderful session. We would like to hear from you in future on the same topic, or maybe on the future aspects of the research. I would also like to thank Dr. Parag Sancheti, Chairman of Sancheti Groups, Mrs. Manisha Sangvi, our Executive Director, Dr. Apurva Shimpi, who's our Principal of Sancheti College of Physiotherapy, entire technical team of Physio TV, and our viewers, of course. Thank you so much. We'll conclude today's session.